Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Ani Annamalai. She is an internal medicine psychiatry physician. Her Kevin MD article is titled Medicare Advantage for My Indigent Patients. Ani, welcome to the show.
Thank you. Thank you for having me here, Kevin.
So we'll get into your article in a little bit, but first off, briefly share your story and journey to where you are today.
So I am an internist and a psychiatrist, as Kevin mentioned. I did a combined internal medicine psychiatry residency at Southern Illinois University, and I graduated in 2008. And then since then, I've been here at Yale School of Medicine in New Haven, Connecticut, more specifically practicing at the Connecticut Mental Health Center. I see patients both for psychiatric and medical problems there. So I see a wide range of problems, plus the article that I wrote and which I'm going to touch upon today relates to the insurance that these people get, which I only started realizing and looking into more lately. So
let me just ask you about your specialty first. So you're both an internal medicine physician and a psychiatrist. So just on your day-to-day typical workflow, what are some typical medical issues that you would see in patients with behavioral health disease?
Yeah. So I see patients with very severe mental illness. So the people that come to us at CMHC are those with schizophrenia, bipolar disorder, major depression, substance use. It could be any of those things, but they come with a lot of medical comorbidities. So I see a lot of diabetes, a lot of hypertension, a lot of risk factors for coronary artery disease, and then sort of many things that we see in regular primary care practice, like hypothyroidism and chronic kidney disease and chronic liver disease, etc. And I have to say, I see and practice a lot more diabetes and hypertension in this population than I would in others, because these people don't easily go for care to other places. So day to day, I would say in the morning, I might be adjusting somebody's antipsychotic, and in the afternoon, I might be treating the diabetes, which could be related to the other treatment that I'm giving them, but it sort of all comes together. So I would say it's sort of the bread and butter of primary care practice, and the psychiatry is a little bit more skewed towards seeing people with very severe illnesses who really cannot or not able to get care anywhere else. That's sort of my population.
So I'm an internal medicine physician, but I'm not a psychiatrist. So tell me that influence. So people who have schizophrenia, how does that make it more difficult or more challenging for you to care for the medical issues like diabetes and hypertension?
Yeah, so there's multiple reasons, and people have written and talked a lot about this, but the fundamental thing is our healthcare system, as we know well, is not easy to access, even for the best of us. And these people often need sort of more time, more tolerance, more patience, even simple things like waiting in a crowded waiting room or waiting half an hour for their appointment because the doctor's running late. Those little things can really throw them off. And also things like adherence, is even more of a problem in this population. And if you sort of treat them as quote unquote non-compliant, that doesn't work as well. You really have to work with their deficiencies and work with the challenges they're facing. And also, we talk a lot about social determinants of health, and that's much more pronounced in this population. Typically, these people have problems with transportation, getting to their appointments, even sometimes having a viable phone number when you make referrals for people to call them. So I would say it's an array of problems. And then also, unfortunately, a lot of the treatments that we do have in psychiatry exacerbate some of the underlying medical conditions they have. So with all this, unfortunately, our people with mental illness do have an increased mortality. They do die several years, actually, earlier than people who do not have any mental illness. And, these are some of the factors, but there's actually many more that we could talk about that it's difficult to address if you also don't have that experience and practice seeing these patients on a day-to-day basis.
As you know, sometimes it's very difficult to get access to behavioral health care. Now, what kind of advice or tips do you have for primary care clinicians who see patients for diabetes and hypertension, but also have those comorbidities like schizophrenia or bipolar disorder or some other mental health illness?
Yeah, right. So that's a very good question that if any of us had a good answer for, I think we would be in a lot better shape now. But I would just say, to the extent possible, primary care physicians, arm themselves with the knowledge, that would help them. And I know a lot of primary care physicians would be comfortable prescribing antidepressants and sort of treating, going through the steps 1, 2, 3 of treating, behavioral health conditions, but may not be as comfortable going beyond that. There are resources for primary care physicians, either within internal medicine societies or conferences, or sometimes going to the psychiatric associations, where sometimes even our group has had courses for primary care physicians, how to treat behavioral health conditions. So arming yourselves with the knowledge, and then I know primary care practices are often strapped for resources, but using your social worker or whoever you have access to find those services in the area. Because oftentimes, even if you don't find anybody easily to treat anxiety or depression, often when it reaches the level that they're having multiple hospitalizations or they need that higher level of care with wraparound services, usually state mental health facilities are available. Again, they have waiting lists and they're not perfect, but a lot of times your local state mental health agency will be able to take them on and provide that resource, just like our CMHC is. It's sort of the local go-to place for people who haven't been able to get care anywhere else.
All right, let's talk about your Kevin MD article titled Medicare Advantage for My Indigent Patients. Now, how did this article come together?
So like most physicians, I knew very little about insurance. And my only annoyance or brush with insurance would be when I got pushback, because I had to do prior authorizations, either for medications or for procedures. And I didn't think much about it until I started exploring this for my own parents who are elderly and who have been on Medicare for a few years. And the last few years, we've been getting more and more advertisements to join one of the Medicare Advantage plans. And we sort of didn't look into it too seriously until this year when they themselves had some health conditions develop. And we thought, okay, we need to look into this more. And when we did that, I realized that there were actually two things. One was the traditional Medicare, and then the Medicare Advantage plans, which I didn't quite realize until then. And I also realized that one of the bigger differences between the two is that the traditional Medicare, only covers about 80% of your costs. And the 20% supplement for most people is hard to cover, and most people need to get a supplemental insurance plan. And the advantage with these Medicare Advantage plans is then it's just one plan. You don't need to get a supplemental plan and you're just covered by one thing. So it seems like a good thing. But while I was thinking through this, I suddenly realized that my patients who also all qualify for what's called a QMB, that's a Qualified Medicaid Beneficiary, when they qualify for the QMB program, anything that Medicare does not cover, including that 20%, is basically paid for by, it's picked up by their QMB, which is usually their local Medicaid. So that's kind of like a backup insurance. Mm-hmm. So then the big benefit that people have in the Advantage program is kind of lost for them. Then I started looking into maybe there are other advantages, other reasons why they should be on this. But the more I looked, the less I found, information there was to convince me that this was a good thing for them. For example, dental benefits are one thing that Medicare Advantage plans frequently offer, but not only do they cover very little for my patients, especially in the state of Connecticut, the Medicaid does cover the dental plans. So that wasn't really an advantage. And then I realized one other important thing, that typically people who are on these Medicare Advantage plans and are even happy with them, when they get sicker, when they get older, when they have more health problems and they need to access healthcare more, seem to want to switch back to the traditional Medicare. To me, that means that if you're sicker, then you actually are going to need this. But if you're mostly healthy and just need your preventive care, then the Advantage plans might be okay. So after all this,
now, what's the reason that they typically want to switch back?
It seems like they're not able to, from what we know, they're not able to access high quality care at specialty hospitals, for example. They have more out of network barriers, for example. And my own personal example that I referenced in my write-up was when my mother needed specialty care, I didn't have to ask the insurance plan. I just took her, even though it was out of state, I took her to a specialty hospital and she was able to receive her care without me ever even talking to the insurance. And that's because the traditional Medicare is accepted by almost everybody, all hospitals in the country. Whereas the Medicare Advantage plans are usually geographically limited and you can't just go to the best care that you want. So typically the reasons seem to be for switching when people need sort of a higher quality care at a specialty hospital, or the number of doctor visits and the number of hospital visits keep increasing and they need higher level of care, and then they start to experience more restrictions and pushbacks from their insurance.
Now, to my understanding, the Medicare Advantage plans, they're mostly run by private insurers and in some cases for-profit insurers. Is that correct?
That's correct. And I don't claim to be an expert on this, but from what I've been reading, once I started getting interested in this, there are a lot of people, for example, Don Berwick, who used to run the Center for Medicaid and Medicaid Services, who has written about this, but they're all for-profit companies. And I think that really incentivizes them to push and aggressively market, which is, I think, my fundamental problem with it. Whether they are better or not can be decided by the individual, but it shouldn't be that when you are eligible for Medicare, all you hear is from the private companies and you hear nothing about the traditional Medicare from the government. That, I think, really it makes for an uneven playing field. And one of the things that I was really surprised by in the last year or so is my peers, whether they're physicians or not, I think have a very limited understanding of this. And I asked several friends who are older, who are on Medicare, what are you on? And most people couldn't really tell me. And my worry is at this point, most people have even forgotten that there is a traditional Medicare option. People, I think, at some level realize there are these private Advantage plans and there are different plans and you have to choose a plan that works for you. But beyond that, I don't think people realize that there's an option even not to be on one of these plans. Unfortunately, traditional Medicare does not have prescription coverage. So everybody needs some private plan for that. But you could choose just to have that, but not have the private plan for your hospital and doctor visits and all that, which I think most people don't realize, which for me was the biggest disappointment when I was learning about all this.
So let's say for your patient population who has a choice, they're about to be 65 and they have a choice between traditional Medicare and Medicare Advantage. What kind of advice are you giving them?
Yeah, so I realized only very recently that, all this that I learned. So I started looking to actually my patients' records, and I confirmed that pretty much everybody that was on Medicare was on an Advantage plan. So I've started talking to people in our clinic, our social workers and other healthcare workers who are there to help these patients about this. I'm trying to increase awareness amongst our community so that they can help me help our patients at least know what their options are. And even if they're choosing to stay with one of the private plans, to choose the one that's best for them. Because as I referenced in my article, I've frequently had situations where the patient will say, oh, my plan changed. And then they'll tell me all the medications that need to be changed, which is unnecessary unless they're actually getting a definitive benefit. So I am hoping to not just directly talk to my patients, but at least within our mental health center to create some sort of system where we at least know where to direct patients. And there is one agency that I came across, which is basically the state Medicare assistance program, which is run by Medicare, which is government sponsored, which I have not personally tested, but I'm hoping that they can give advice that's neutral. Because when you have an incentive, then your advice is not going to be neutral, which any Advantage insurance agent will have an incentive to sell his or her plan. So I want people to go to a place where they get advice that's not biased. And I'm trying to make that happen in our workplace, at least before the next insurance enrollment period comes, this coming November.
Now, for someone who's listening to this and may want to switch from Medicare Advantage back to traditional Medicare, what's the process for that?
So Medicare.gov can be quite helpful. There's actually a process where, especially if you know how to navigate it, and again, it might be difficult for people like my patients, they might need help, but just calling the Medicare number or navigating through their website, you can actually put your geographic reason and the things you want and what you need to do, and it'll actually take you through the process. But especially when you call Medicare representatives out of the insurance enrollment period, they will have more time. So I would actually encourage people to do that before the enrollment period starts, to just get all the information ready so that they can make that switch. And I would also say, just even for the physicians listening to this, for themselves, when they're heading towards Medicare, to just look into this, to really do the due diligence and do the research before, just signing up to a plan when you become eligible.
We're talking to Ani Annamalai. She is an internal medicine physician and psychiatrist. Her Kevin MD article is titled Medicare Advantage for My Indigent Patients. Ani, what are some of your take-home messages that you want to leave with the Kevin MD audience?
So I think we all as physicians have a ton of things to do, and we are very busy and we don't have time, barely have time even to see patients. But I would really encourage people to get immersed in this a little bit more and understand sort of what system is being run for our healthcare. And we all know this is not a novel idea, this is not new, but I think I just want to emphasize that our healthcare system is too fragmented, and healthcare really shouldn't be a commodity. It shouldn't be this complicated for us to understand. And I think in whatever little way we can, whether it's by helping our own patients or whether it's making systemic changes or advocating to our elected officials, I think we should all try to do a little bit to make our healthcare system simpler than it is now.
Ani, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you, Kevin.